So yeah, you're exactly right. The left ventricle is the main pumping station for the entire body. The right ventricle, its primary duty is to pump the blood from the heart to the lungs and back. So it doesn't have very far to go. As we said on Monday, the left ventricle itself pumps it all the way through the body. Now, as we're looking at this and we're dealing with this particular problem, one of the things that we need to become really, really very familiar with, and now you're ahead of the game here because of what you've already done, is that we got to begin to understand the cardiac conduction system. The conduction system in the heart is much like a train system. Okay, we have tracks that run along through different cells within the heart, within the muscle itself. And what that does is it conducts electricity. These are specialized cells that conduct electricity. But now, again, remember, what did we talk about on Monday that said one of the principles of the heart had that no other muscle had? And what is that?
It's the ability of the pacemaker cells to automatically make electrical impulses from the sinus atrium.
So what if the pacemaker cells fail? Where does the impulse come from then? Okay, so we can get from that. There's really no ventricular node. We do have an SA node in the ventricle.
AV node.
Okay, so so each one of the sections of that conduction system. But the other thing to remember with automaticity is even if the SA, the AV, the bundle of His, the left and right bundle branch, and the Purkinje fibers fail, every individual cell itself can now become a pacemaker. That's not ideal, okay, under most circumstances. But again, what these do is that they initiate and they distribute electricity throughout the myocardial itself, okay? Now, the primary pacing area is going to be the SA node, the sinoatrial node. And if you'll remember, it's located right up in here. It's kind of a crescent-shaped piece of specialized tissue that is at the very top of the right ventricle, and that is what's called the intrinsic, or the normal, or the master pacemaker of the heart. And that's where, under normal circumstances, where our impulses will begin. Now, if that fails, then the atrial cells can kick in. Here's the interesting thing is, unless there's something really, really bad, you and I as paramedics are not going to know whether it's coming from the SA node or the atria, because again, the SA node, the intrinsic pacing rate that we said Monday is what? How often does the SA node depolarize every minute? 60 to 100. Excellent. Very good. So it depolarizes 60 to 100. If the SA node fails and the atria begins to pick up, the atria itself will also depolarize at 60 to 100 beats or impulses per minute. And so that's the key thing to kind of to keep in context there for that particular area there. Again, as we're coming down, and we'll look at, as we're coming down the list, moving down closer to the ventricles, the intrinsic pacing rate begins to slow. And it becomes more critical now that we fix the problem of whatever it is, if we can, that is delaying the impulses to being paced. Now, again, remember, automaticity is a critical concept for you to remember. We also talked about excitability. What is excitability?
The ability of the cells to know when somebody's going off that the rest of them go off.
Yeah. So it's much like depolarize, 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 depolarize. And it goes out in all different directions. And the depolarization happens so fast that it's almost instantaneous. Not quite, but it's almost instantaneous, okay? It goes on and through there. And again, we talked about the fact that the heart itself can continue to beat for a period of time, even when it's removed from the body. Okay, why? Because it has that automaticity. It does not need the brain for a very short period of time to tell it to beat. And that's a really, really good thing for us as far as when we're looking at there. All right, let me get ahead here because I've kind of talked about it. Now, again, this is going to be everything that we're talking about from here on out is going to be foundational. Okay, so you got to know it, and then we're going to build on top of that, and then we're going to build on top of that, much like we're building a house. So again, this is some foundational material. We've got our SA node that is up in here. That's the primary pacemaker. It depolarizes at about 60 to 100 beats per minute. And what we're going to talk about is we're going to talk about the normal circumstances first. Okay. One of the things that's really important is that we've got to learn what normal is when it refers to the heart itself. Why? Because the illustration I like to give is like for the United States Secret Service, part of their responsibilities is to look for, identify, and prevent counterfeiting of American money. Well, how do they do that? Well, they become an expert in what American money looks like. They spend a little bit of time of studying about counterfeiting techniques, but basically what they do is that they look at the American $1, $5, $10, $100, whatever it is that they're studying, and they become an expert in this is what has to be there in order for this to be genuine American currency. That way, when somebody hands them another thing that looks just like, if they find one thing that is either in there that shouldn't be or not there that should be, they say this is counterfeit because we become an expert at knowing what normal is. That's the first step for y'all as well. We got to become knowing what normal is, and that's going to tie into those waveforms we talked about. Now, when the SA node fires, there's two things that happens. Again, because of that excitability, it shares the impulse cell to cell to cell, and it does this by way of a tract of nerve tissue that comes over here to the right ventricle. That tract is known as Bachman's bundle, Bachmans bundle, okay? The other thing that it does is, remember, we got to get the impulse over here, but we also have to get the impulse down here. So it comes from here down to here to the AV node by the intranodal pathways. Intra meaning within, okay? So two things that happen, again, when the SA node fires, sends it over to the right or to the left atria through Bachman's bundle. It is also connected down into here by way of the intranodal pathway. That brings us to our second stop on our railroad track, and that is the AV node, or the atrial ventricular node. That's right, if you can look at it, it's right here at the very beginning of the demarcation between the atria and the ventricles over on the right side. So that's our AV node. The AV node itself can also generate impulses, except its normal intrinsic master pacing rate for the AV node is 40 to 60 impulses a minute. That's important because knowing what the normal rates are for these different pacing sites is going to help you to be able to identify where that it's coming from. I promise you, it's like a puzzle. It'll all come together. Sir, 40 to 60, 40 to 60. So, now that does not mean that the AV node, if it's damaged, can't beat slower or it can't beat faster. But again, there are some identifying characteristics that when we look at that graph on the EKG as to what is going to appear there, and it will help us to be able to identify what's going on. So again, yes?
When the SN node or SA node goes over to the Bachman's bundle, does that contract the left atria and make the backside of the
Excellent.
P wave?
Yep, you're exactly right.
If our P wave's off, that's going to be altered sinus P wave because the signal's not reaching the vagal level.
So, I love your question. Let me think how to answer it. So when the SA node fires and it sends that signal out over to the left atria and down to the AV node, it's going to generate a P wave, okay? And that P wave is going to be upright, okay? Now, the P wave can have different shapes. It can be rounded, or it could actually be kind of like the peak of a roof. In that situation, we're not really caring about what the shape of the P wave is. It's just we want to see the P wave going up this way. And that tells us that all of the cells in the atria have depolarized. Now, if some of the cells don't depolarize, because remember, the atria is only about, your left atria and right atria is only about that big right there, as opposed to 75% of your heart being the left ventricle, we're never going to see any difference in the P wave. Okay. Now, that's going to come into play here in just maybe next week when we start putting these different electrical impulses to how they look on the EKG monitor. Very good. Anybody else? All right, good. So it comes over here, it comes down to the AV node. And what happens at the AV node is it gets held up for a fraction of a second. Anybody know why?
To allow the time for the atrial kick between the atria and the ventricles.
Perfect. So we've got to allow the atria to completely empty into the ventricles, and then the ventricles will contract again. I can promise you, you will see some questions between now and the end of your paramedic education here on the role of the AV node. So go ahead and dig into that, all right? So the purpose of it is to hold it up so that the atria can finish out dumping all the blood down into the ventricles, which, by the way, let's go over to this table back here. That volume of blood that's in the atria, what did I say it was called on Monday? Anybody remember? Can you help them out? Starts with a P. Preload. All right, so you say, okay, shout it out. Remember, I'm hard of hearing. So again, it's preload, okay? And again, that's going to be a concept in particular that you'll use in cardiology, medical emergencies, trauma, regardless of what type of patient that you're dealing with, okay? So make sure that you're familiar with that. Again, gets held up here, but if this all fails, if the SA node fails, if the atria fails to pace, then our AV node is going to be picking up. Next part of our train trip here is going to be this bundle of specialized tissues that is rather thick. It's called the bundle of His, not the bundle of His, but the bundle of His. The purpose for the bundle of His is that it's now getting ready to separate that impulse that has been one impulse so far. Now it's going to begin to separate it out into two tracks. And that's going to be critically important as far as when we're looking at what's going to be happening in the ventricles. It comes away from the bundle of His. Now it comes down what is known as the bundle branches. You have two bundle branches. You have the left bundle branch and you have the right bundle branch. Anybody remember what this piece of tissue is called right in here? Say it again.
The septum.
The septum. Good. So it's right down in and through here that it's going to have the conduction that is coming through. And this is the left bundle branch. This is the right bundle branch. There is a way, if there is a block, that you can tell if it's a left bundle branch or a right bundle branch. You will not learn that in this class. Every semester I have someone, when I give a quiz or an exam, I'll give them a rhythm strip and they'll write down left bundle branch or right bundle branch. Wrong. I can tell you right now, that's going to be wrong because all of the EKG strips I'm going to give you is going to be in a specialized view called lead 2. It takes a different view that we can only get from a 12 lead, which you'll learn about in advanced cardiology, to identify whether there is a bundle branch there or not. So let me save you some grief. Don't write down left or right bundle branch on any of the rhythm strips. As it continues on down, now it gets down here into the apex of the heart. Remember, The bottom of the heart is called the apex. The top of the heart is called the base. Okay. And I did a little more research. The reason it's called the base is that it is actually anchored in the chest up here to help to keep it from moving. This part is not anchored, so it allows it to move, which is a good thing when it contracts. So it comes on down here, and now it begins to go out on little side tracks all through this particular part of the cardiac muscle. And this is known as the Purkinje fibers. The Purkinje fibers. Now, here's the thing to remember. Both the Purkinje fibers as well as the tissue of the ventricles can act as pacemakers. Anybody have any idea what the pacing rate of the ventricles might be?
20 to 40.
20 to 40. Okay, good. Now, as you can see, as we're looking at here, we start up in here with the SA node and the atria at 60 to 100. And then we come down here to the AV node to 40 to 60. And then we come down here to the ventricles of 20 to 40. Under normal circumstances, a patient is not going to be able to live long with a heart rate of 20 to 40. Now, some people have heart rates in the 40s, and that's their normal. We call those people extreme ultra athletes. People like long distance runners, swimmers, will often have a heart rate, especially when they're sleeping, in the mid to low 40s. That's completely normal for them. You ever respond to my house and I have a heart rate of 40, please do something, because obviously I'm not an athlete of anything. Yes, sir.
So if it is in that 40 range and it's normal, is that coming from the Purkinje fibers, or is that from the SA node normally?
Good question. It will be a perfect looking, what we call sinus bradycardia. It's being generated up in here, and it's following all the normal conduction pathways. It's just because of the way that they have worked, they've exercised, and again, these athletes that are like up in the top 5% of that now their heart has become so efficient that it doesn't have to beat as much. Good question. Yes?
So would that change like the rate for the AV node and the ventricles?
All right, so let me ask you a question. So again, did we talk about the phrase treat your patient and not the monitor on Monday? Okay, I see some heads yes and some no. So one of the things that you'll hear in EMS and in medicine in general, especially emergency medicine, is that regardless of what you see on your monitor, look to your patient and let your patient guide you as to what your treatment is going to be. Now, we have these monitors, and we have them for a good reason, because they give us pieces of the puzzle, but they don't give us the whole picture. Now, in regards to yours, the short answer to your question would be yes. The pacing rates for the others would be slower, just simply because of the way that it's made. Now, let's think about that for just a minute. I've given you two examples. Michael Phelps, swimmer, his resting heart rate is in the mid 40s. Bill Young, competitive eater. My resting heart rate is nowhere near in the mid 40s. If both of us presented to you with a heart rate of 44, what would be the differences, not looking at the monitor, but looking at me as a patient? What would be some of the differences that you would see in me as opposed to Michael Phelps?
Narcoleptic signs,
Tell me more about what that is.
blue lips, I would think would be a big one.
Yeah.
Low pulse.
Well, now we both got low pulse. So, yes.
I would say like either really high blood pressure or just kind of altered mental.
So again, the blood pressure, again, for Michael Phelps, his blood pressure is probably going to be in the low range of normal, okay? Mine's going to be in the toilet, okay? Because of a rate of 42, 45 would not be enough to sustain me. So my blood pressure would be really, really low. Go ahead.
So am I mistaken in this? Because at one point I've been taught from like a medic buddy of mine that the lower the heart rate, the higher the pressure. Is that not correct?
No, it's not in straight cardiology. Now, again, we'll take a little side trip here. when you have a patient that's got head trauma and the intracranial pressure goes up in there, one of the things that happens is their heart rate will begin to get really slow, but we'll see astronomical blood pressures of like 220 over 160, 180. In that situation, you would. But in almost all situations of cardiac disease, if a patient has got a pathological type of heart rate in the 40s, they're not going to be doing well. Okay. Anything else? Yes. Rapid breathing. Okay. So again, that's part of that compensatory process of trying to get air going into the lungs and around to the body. Okay. Now I want to come back here to the septum and to this dividing line in here. When you're looking at an EKG, again, you're only going to be looking at one view, okay? One view only. When you get into advanced cardiology, you'll look at 12, all right? But again, one of the ways that we're able to look at here is we can look at, through a 12 lead, this part of the tissue here. Understand that if we have death of tissue in the septum, it's almost always going to involve death of tissue of either the left bundle branch, the right bundle branch, or both of them. As a result of that, your heart rate will usually be slow. Okay, I'm going to leave that with you for just, that's as far as I'm going to go on that. But that's going to be the thing that we're going to be looking at in that regard. Okay, that's your conduction system, folks. SA node, Bachman's bundle over to the left atria, intranodal pathway down to the AV node. AV node into the bundle of His, bundle of His into the Purkinje fiber, or bundle of His into the left and right bundle branches, and then bundle branches into the Purkinje system or the Purkinje fibers, whichever one you want to call it. I can tell you right now, when you come back a week from today, don't come in on Monday, nobody will be here. Okay, it's Labor Day. And when you come back on next Wednesday, 2 questions that I will ask you. Okay. One will be put it in the right order, and that's what I just gave you, the conduction system. I'll lay it out for you, and I will tell you to put it in the correct order. The second question I can guarantee that will be on your quiz next week will be knowing the inherent pacing rate of the SA node, of the AV node, and of the ventricles. Now, again, when we say ventricles, we mean Purkinje fibers, and when we say Purkinje fibers, we mean ventricles, so they're interchangeable. So right now, I've told you 2 questions that'll be on your quiz for next week. All right, sir?
What are the ventricle pacing?
Excellent. So with a ventricular pacing, that's going to be 20 to 40 impulses per minute. Now, again, remember I said with the SA node, we can either get slower than 60, and we call that a bradycardia, or we can get faster than 100, and we call that a tachycardia. The same thing holds true for both the AV node and the ventricles. So we can have a pacing rate in the AV node of less than 40 or higher than 60. We will see some changes in the EKG that will let us know that is coming from there. And you'll learn those rhythms. Same way with the ventricles. We can see a pacing rate that is slower than 20 or faster, often much faster than 40 in the ventricles to lead into that. Good question. Very, very good question. All right, let me get through my notes here because I got ahead of myself. Okay. One of the things, and again, coming down in through here, remember I said that we can run into certain types of heart blocks. If we get damage to the AV node, either through hypoxia, either through a congenital issue of where a patient is just kind of born with it, or because of age or medication, and we get damage done to the AV node, that holding up of that impulse now may become wonky. Another technical medical term here, wonky, all right? And because of that, we will see some differences in what we're going to be calling the PR interval on the EKGs. That will be coming up next, maybe even today, as far as when we're getting in through this. So again, everybody good on the conduction pathway? Yes, sir.
When you say that, is that like a PVC that you talked about?
No, actually, that would be one of the heart blocks, like first degree heart block or all the way up to third degree heart block. And the interesting thing about the heart blocks with the damage here is that if a person, and you'll learn these, if a person has heart block, if we did EKGs on all of us in here, I can almost guarantee you there would be at least two of you that here that would have a first degree heart block. You would probably be the youngest members of the class, because a first degree heart block usually comes about because the conduction system is not fully matured until you hit about 25. Okay? So a first degree heart block, we look at it and we go, big deal. We don't really care. It's not going to hurt a patient. Third degree heart block, now we got problems. Okay, this patient is a critical patient. They're going straight to the cath lab, and they're probably going to get a pacemaker. And you may even do some pacing on them with your monitor. So again, understanding the wide ranges of that first degree block up to third degree block are critical. Good questions. Anybody else? Absolutely. I love teaching about heart blocks because they are just so doggone interesting to me. And hopefully you will too. So they're really quite interesting. So let me get through my notes here. Okay. Now, electrolytes. Electrolyte. The word electrolyte is simply chemicals, minerals. That's what I'm trying to think of. Minerals that are dissolved in water. Okay. You go out, those of you that are, thank goodness we've got false fall here. Like I told you on Monday, don't be deceived. Summer will be back. But again, when summer was here, if you were working outside, if you were practicing for softball, if you're at some other sport, you probably got depleted and you drank Powerade, Gatorade, whatever it is. And those had small amounts of electrolytes in them. Okay, electrolytes are really, really important for our muscles because they add to and they help both the electrical conduction and contraction of all of our muscles. Now, obviously, in this class, we're going to primarily focus on one muscle. And that's what I want you to think of the heart as a muscle, okay? And so the electrolytes that we're going to focus in on here, the three of them that are going to be critical for you to know are sodium, potassium, and calcium. Okay? Sodium, potassium, and calcium. Now, let me see my notes here because I want to stay on track. There is a mechanism in the heart. Actually, let me back up. Yeah, it's in the heart. Happens in the heart and happens in the brain. But again, we're talking about the heart. So there's a mechanism, okay? It's called the sodium-potassium pump, okay? I'm going to give you a really, really simple understanding of the sodium-potassium pump. Right? It's important for you to know as a paramedic because, again, on some of your EKGs and some of your patients, if they have elevated or deficient levels of sodium and or potassium, you will begin to see what I call FLBs on the monitor. Funny looking beats. Some of them are, they're just kind of weird looking and it's interesting to look at. Some mean you need to get ready, your patient's getting ready to arrest. It's my job to help you to learn the difference between the two. So here's what happens, okay? Potassium resides within the cell, okay? It stays within the cell except for a very short period of time. Sodium resides on the outside of the cell, all right? Now, through an active process called active transport, basically in the heart, this is what happens. So sodium now begins to diffuse outside. Potassium begins to diffuse outside. Sodium begins to diffuse inside. And the best way, the simplest way it is for me to understand is that when those two minerals cross each other, they cause a spark. That's your electrical impulse. That's your sodium potassium pump. The movement of sodium to the outside of the cell, the movement of potassium to the outside of the cell, sodium to the inside of the cell, and when they cross, they cause a spark. That's the impulse. Under normal circumstances, that's where your impulse from the SA node is coming from. All right? Now, if we get an abnormal amount, in particular of potassium, it can lead into all kinds of life-threatening arrhythmias for a patient. Same way if we get abnormal amounts of potassium, it leads into a problem. It is rare that your patient is going to have too low of an amount of sodium. Why?
The sodium is the biggest factor in food or something.
Yeah, I know what you're saying. How many people are originally from the South? We like our food fried, and we like our food salty. Okay? And that,
Can you repeat what the SA known with the sodium, potassium, like with the SA known?
no,
Okay.
I'm joking. You're talking about the pump?
Yeah, like what
Okay.
does the SA know? How does it? Is it like the impulse?
That's the primary place where our impulses come
Okay,
from.
I just wanted to make sure.
Yeah, no. Please do not ever hesitate to ask questions. That's what you have paid for. Okay. And again, one of the things I promise this to all classes, is I don't know the answer. I'll tell you, I'm not going to BS you. I'm okay to say I don't know, because there's too much in medicine for everybody to know. But I will try to find an answer for you. So again, much like he said, we have plenty of salt in the body. So many times we run a problem of having too high of a sodium, which results in some vasoconstriction and water retention for our blood pressure. But especially we're very concerned about high levels of potassium. Why is that? Well, think of it this way. This is not advocating for or against. It's just a pathophysiological reality. When prisoners are condemned to death by lethal injection, they typically get 3 types of injections. The first one is an anesthetic that puts them out. The second one is going to be a massive dose of potassium chloride. And what that literally does is unplug the heart. It shuts the heart down because you get this massive dose. I mean, hundreds of times higher than what a normal dose would be. It unplugs the heart. And the third one is a paralytic that stops their breathing. This is why having high potassium levels is very, very dangerous for patients. Now, let me ask you a question. Let's think about different patient populations. What do you think would be one patient population that may indeed have a chronically high potassium level? Guesses are okay. Nobody's going to laugh at you. Yeah. Probably not. Probably not. It's an interesting concept, though. Who do you think? Who would have, these are sick people, by the way, but they would have chronically high. Chronically means just long-term high potassium levels. I'll wait for another guess. Sir?
Would be the elderly?
Yes, that's not the group I'm thinking about, but again, they would also begin to fall into that. And many times it's because of what I'm thinking about. The key thing here is elderly is a good answer, The group that I'm thinking about, though, are people in renal failure. Okay, kidneys fail. One of the things that the kidneys does is it helps to filter out not only pathogens and waste products, but it also helps to filter out excess levels of electrolytes. And so when the kidneys fail, guess what happens? Potassium begins to go up and up and up until they go to dialysis, and then it drops down quickly. That's why your dialysis patients almost always have some type of a cardiac issue that's occurring as well. Yes, sir.
That was
Okay. So yeah, so if you're transporting dialysis patients, this is the thing you got to remember is that they never feel good. They're never feeling good. Dialysis is not to make them feel better. It's actually to make them feel a little bit less worse. But that's the thing to remember. So that's your potassium and that's your sodium. What was the third electrolyte that I said was important? Calcium. Now, what did your moms tell you about drinking your milk? Why? It makes your bones stronger. She's right in that regard, but guess what? Not only does calcium make your bones stronger, but it also is the electrolyte that causes your muscles, all of them, but in particular the heart, to have that mechanical action. Okay? That mechanical action. Rarely do patients have too high of a level of calcium. But if it is, would you think? Do you think it would make the heart beat harder or weaker?
They'd be in SVT if they had more of that.
Now remember, calcium doesn't affect the rate. That's going to be your sodium potassium. How fast or how slow it pumps out. Calcium is the mechanical action, the actual contractile force of the heart. So do you think it would make it beat harder or easier if calcium is high? Make it beat harder? Yeah, you're exactly right. Under normal circumstances, that would be a good thing. But again, what is one thing that might happen? It kind of comes back to what you were talking about earlier. I don't want to say anything else, that if your heart is beating too hard for too long, what type of diagnostic might be kind of wonky? Say it again. Hypertension. Remember, so the heart is pumping, it's working harder, it's pumping more blood through the vessels. If they don't dilate, that raises the blood pressure, and now we wind up with hypertension. Good. So what happens if calcium levels are too low?
With hypotension.
So you're exactly right. So we could literally wind up with a low blood pressure, hypotension. Good. Sir.
Cardiac regurgitation at that point?
Probably not, because the regurgitation comes about as a result of the failure of the valves. Now, you can have a disease process. You can get old and your valves begin to fail. And they can go in and they can put in artificial valves, which is really kind of weird. I'll try to find an audio for you. Basically, when you're listening to the heart, you hear lubbed up. We're used to that, okay? When you got a person that's got an artificial valve, you hear lub click, because it's different type of material. Yes, sir.
Did you just have like mechanical failure?
Absolutely. As a matter of fact, you'll learn about a rhythm in here that you have to be able to identify, in which when you look at your monitor, it could be the most beautiful, normal rhythm you've ever seen, and yet your patient is in cardiac arrest. You got electrical activity, but you have no mechanical activity that's going on whatsoever. Go ahead.
So when someone like refers to PPA,
That's what it is. Yep, you're exactly right. Very good. All right. So really dig into the material about sodium, potassium, and calcium. Now, when you get into advanced sequence, we'll be adding some other things like magnesium and how it comes into play and why it's really important for addressing some rhythms. But for right now, those are the three electrolytes I want you to become really strong in between now and the end of the semester. Okay. Now, when we're looking at EKGs, remember you'll hear it often called either one of these, EKG or ECC, okay? Most of the time you will hear it called an EKG because an ECG sounds an awful lot like an EEG. Both measure electrical activity, but the ECG measures electrical activity in the brain, okay? Where do we get the K? Well, the guy who discovered how to monitor a heart was a doctor by the name of Dr. William Einthoven, German doctor. And so the word for cardio in German is K. Starts with a K, not a C. That's where we get EKG. Now, again, I want to stress this too, because this is really, really important. When you're looking at a monitor and you see that little bouncing ball go across, or you're looking at a paper strip and you're going, I have no idea what Bill has given me here. That's just electrical activity. The only way, Skylar, that you can measure output, mechanical action, is by touching your patient, checking a pulse. We'll talk about that when we talk about assessment. Feeling the skin. Is the skin warm? Is it pink? Is the patient diaphoretic? That's another word you need to learn. Diaphoresis means sweating, okay? Sometimes we sweat when it's normal. We've had some heat indices over the summer of about 115. Trust me, people sweat, okay? And that's normal. But when it's 32 degrees outside and your patient's outside and they're sweating, that's not normal. That's not coming from heat. So that's diaphoresis, all right? And so, again, you need both. You need the monitor and you need your hands in order to assess your patient. Now, a couple of things to understand here. First of all, we're going to look at, what was that?
Table.
Okay, that's all right. It's just a new sound I'd never heard. I thought, that's an interesting ringtone. So, anytime that we have this horizontal line in on here, that's called our baseline. Now, of course, if that horizontal line is too long, we call that a systole. We call that patient dead. Okay? Not a good time. Okay? So, under normal circumstances, this is our baseline. Now, one of the things you have to understand is that when we put electrodes on our patient, and for this class, you'll learn, you'll put some electrodes on each other. You're going to use 4 electrodes. You're going to put one here, you're going to put one here. You're going to put one here, and you're going to put one here. These are called the limb leads because, again, when our good buddy Dr. Einthoven started out with EKGs, literally what he did was that he put both his hands and one of his feet in salt water. And then he hooked himself up to some wires that led into the buckets of salt water, and that's how he picked up the electricity. So these are called limb leads. The upper limb leads for your arms, and the lower limb leads down here for your legs. But now we put them on the chest. It's just easier. Patients will move their arms and legs, which will result in interference. So again, the thing that we're looking at here is that electricity, when it's going towards a positive electrode, and we'll talk more about which ones are positive and which ones are negative. But when it is going towards the positive electrode, we will get a deflection that goes up, okay? When it's going away from the positive electrode, it'll be just like this. We will get a depolarization that will go down. Now, in EMC 303, we probably won't go a whole lot deeper than that. And I'll repeat that again several times. But that will become really important to you when we've got 10 leads on and we're looking at 12 different views, because we've got to make sure that those leads are put on in the right place. And we understand, that should be a positive deflection going above the baseline, but it's not. I wonder what's going on with it, okay? The same way is true as far as a negative deflection. So again, remember, as you head towards the positive, your deflection goes above the baseline. As you head away from the positive, and it needs to go down below the baseline as far as that when you will get there. Now let's talk about paper, okay? Wednesday, I'll try to remember to bring in some paper for you that you can actually look at, see and feel and hold and mark on. EKG paper is nothing more than graph paper. That's all that it is, okay? However, this is specialized graph paper. Along the top here, you will see different hash marks. Most of the time, what you will see is, let me back up. Let me tell you what these stand for. Okay, these hash marks represent time. When we are looking at the different deflections on an EKG, the horizontal reflections that we're looking at. So when we're reading it, we're looking from this way to this way. We're talking about time, okay? When we're looking at the different deflections going up and down, we're talking about voltage, okay? So in a very small way, really small way, because I don't know a lot about electricity, I'm going to teach you kind of to be electricians here, okay? So again, remember, the horizontal line represents time, vertical line represents voltage. Now, up here at the top, you see that we've got a bunch of different little hash marks. On this particular example of the EKG paper, in between each one of those hash marks represents 2 seconds of time. Now, this is going to become important to you in just a little bit. So this would be 2 seconds. This would be an additional 2 seconds, an additional 2 seconds, an additional 2 seconds. So we would be looking at 2, 4, 6, 8 seconds of time that we would be recording this EKG on this piece of paper. Under most circumstances, you don't see a 2-second division, you see a 3-second division. So instead of having 2 seconds of these, you would see 3 seconds. All of the EKGs that I will give you will have the hash marks at 3-second intervals. Now, let me say that again to make sure everybody understands. Because again, we're going to use these hash marks to help us to calculate the heart rate, not the pulse. Because remember, you can only assess a pulse by touching your patient. But we can look at the monitor and we can determine what the patient's heart rate is. Okay? So again, all of the pieces of paper that I will give you, all of the EKG strips that I will give you, if it has hash marks at the top, that will be, between those hash marks will be 3 seconds. The other thing you need to remember, sometimes I will give you EKG strips that have no hash marks at the top. When you see no hash marks, you can safely work off the assumption that what you're looking at, that whole strip right there, is a total of 6 seconds, okay? So if you got hash marks at the top, that's 3 seconds between hash mark. If you have no hash marks at the top, that's going to be a total of 6 seconds for the entire strip. Let me pause there and make sure everybody cool with that. Everybody understand that.
Can you show her like the 2 seconds? Is it like between like hash mark and hash mark, like to each one then?
For which one?
The 2 seconds.
So this is a 2-second one here.
Okay.
So you will see more hash marks here. So that's what we'll be looking at. So again, we were at 2, 4, 6. And so generally what we would have here is that we would take one of these out and there would be one in the middle, and that would be 3 seconds.
Okay.
That help?
Yeah.
Okay. I'll put up an example, and probably what I'll do is I'll just simply email it out to you of an example of both a 3-second interval and an EKG that it would be considered a 6-second EKG. That'll help you a little bit as well. Okay, let me get going in the right direction. All right, so let's talk about what's happening in the heart and what you're going to begin to see on the paper, okay? So now remember, Normal circumstances, because that's what we're going to be working, okay? Under normal circumstances, what is the first part of the heart to depolarize? Nope.
Did it?
What is the first part of the heart to depolarize?
SA?
The SA node, which is in the atrium. Okay, so the SA node depolarizes. Now remember, when it depolarizes, it sends the impulse over here by way of Bachman's bundle. Okay, if you want to make an old man happy, go Google Bachman Turner Overdrive, one of the greatest bands of the 1970s. That's how I remember it. Okay. So Bachman's bundle comes over here. Down here it comes through the internodal pathway. And remember, through that process of excitability, it shares the impulse with the cell to the cell to the cell to the cell. As a result, we wind up with a P wave. Okay? Don't ask me how they pick the letters. Don't have a clue. But this is the P wave. P wave represents atrial depolarization. Okay? Atrial depolarization. Next thing that happens is, look at this. Now, what did I say this part of the EKG was called?
Your baseline.
The baseline. Very good. So it gets held up here, and for a brief fraction of a second, nothing's happening. Okay, why is that? Well, I'm glad you asked. The impulse gets held up right here at the it's at the AV node. Okay. The reason being is that when the heart contracts, atria contracts, ventricles are open. When the ventricles contract, the atria are open. That allows the maximum amount of preload. And preload is what? Volume of what?
Blood.
Volume of blood that the heart has access to. And because of that momentary pause at the AV node, now what we have is another part of our baseline. What this is called is let me come on down here. So when it's done, it gets sent from the AV node to what's the next stop on the train? Bundle of hips. So when we get this down in here, we get atrial depolarization and held up at the AV node. We have this little section right in here. We have the P wave. We've already seen that. But the measurement from the beginning of the P wave to the very beginning of the QRS, and we'll talk about why it's called QRS, even though not all the parts may be there, is called the PR interval. That's going to be an important measurement that you got to become an expert at. Okay, that's the PR interval. All right. Now, remember, down in here, down towards the pointy part of the heart, that's known as the apex of the heart. Up in here, this is called the base of the heart. The reason being is because the base of the heart is actually anchored in the chest. The apex is not. That's what allows it to contract and to expand. So as it sends it on down in through here, down from the bundle of his to the, not yet, left and right bundle branch down into the Purkinje's, then now we begin to get the depolarization of the ventricles. Now, why don't you look at something? Look how the atria depolarizes, and look at this. The ventricles now begin to depolarize in the opposite direction. Again, that is to maximize blood flow. Atria only has to send blood from here to here. The ventricles, on the other hand, the right ventricle has to send the blood out to the lungs and back. The left ventricle has to send the blood all the way through the body and back. Because of the structure of the heart, remember, atria dumps blood into here. Now, ventricles, we've got two things that are up in here. So this is our aorta that's coming out, and then alongside the backside, we have the left and the right pulmonary arteries. to go out to the heart. That's why they come out right up here near the base of the heart. So again, once the ventricles have completely depolarized, now we have our QRS. Now, the QRS will not always have a Q or an R wave, but we still call it the QRS. All right. Now, this is how we tell the difference. Your Q wave is the first negative deflection after your P wave. It goes below the baseline. Okay. The R wave is the first positive deflection after the P wave. And then your S wave, regardless of whether it goes down or whether it goes up, because again, when we're talking about advanced cardiology, there will be some leads you'll look at that the EKG or the QRS will be upright, and then other parts of that same EKG, they will be inverted. That's normal, okay? The S wave comes all the way back up to where it joins the baseline right there. Everybody with me so far? Okay. It rejoins the baseline, and this isn't listed, but it's important for you to know right now, to the baseline, and that's called the J point. We'll talk more about the J point probably in the last couple of weeks of the semester. It'll become critically important to you when you get into the advanced sequence, okay? Then what happens, remember, the ventricles depolarize from the apex up towards the base, and as such, they begin to repolarize the exact same way, resulting in what is called the T wave. Okay, the T wave. Sir.
Just really quick, where did you say that J point was specifically?
Stand by. So, right up here, and sometimes it's difficult to locate because of the way the EKG is printed, but it comes right back up here. Your J point is where the S wave rejoins the baseline. Good question. So it begins to repolarize, and that gives us our T wave. Now, ladies and gentlemen, boys and girls, what's the difference between depolarization and repolarization?
When is it at rest? Or is it resting?
The heart is at rest, but there's activity that's occurring. Yes, sir. It's related to voltage. Let me ask you a question. Let's say you're a police officer, military, or you're just a gun enthusiast. Let's say that you're practicing shooting your weapon. When the weapon's empty, what do you have to do? You reload. That's the same as depolarization and repolarization. So when you're firing your weapon, that's depolarization. When you stop to reload, that's repolarization. Remember that pesky little sodium potassium pump we talked about? That's what happens right here. So as we're coming down through here, all these cells, and then it comes down in here, now what happens is that we get that impulse that generates up in there, and the cells do this. They depolarize, and they share that electrical impulse with a cell that's next to them, kind of like dominoes. In the repolarization phase, this is what happens now. It's back to normal, and that's the part of where it would be chemically at rest, okay? Now, I just told you the T wave is evidence of repolarization of the ventricles. For the life of me, I don't see any place up there that gives us evidence of repolarization of the atria. What's up with that?
The QRS complex takes it over.
Yeah. Remember, the atria are really, really small. The right atria is about that big right there, okay? It balloons out. But again, the ventricles will take up probably about 90 to 92% of the heart. They're the big dogs. And as they begin to repolarize, we will see this T wave. The atria will repolarize. They will indeed generate a repolarization wave, but it's teeny, teeny, tiny, and it's lost here in the QRS. Okay? And so that's depolarization and repolarization. Yes, sir.
Someone talks about a D wave. Is that the atrium? Atrium repolarized?
Not familiar with what a D wave is. I'll have to look. Okay. I'll take a look and see. Last thing I want to talk about is this repolarization. We have absolute repolarization and we have relative repolarization. Now, let's go back to this right here, okay? Remember, when we're talking about absolute and relative repolarization, we're talking about the ventricles. The ventricles make up the vast majority of the heart. In absolute repolarization, that says that sometimes the heart, because of disease, because of malformation, because of certain drugs or chemicals the patient may be taking, will occasionally throw out extra beats. Those extra beats are called ectopics, ECTOPICS, ectopics. Those ectopics are usually going to be just kind of a nuisance. The patient will feel them, it's a little uncomfortable, then it goes away. Now, if these ectopics hit on a certain part of the EKG, this can lead our patient to go into instant ventricular fibrillation and instant death, okay? So where it comes about is all about the T wave. So from this point right here, at the, what did we say that point was right there?
J.
Outstanding. From the J point up to the peak of the T wave, that is known as the absolute refractory period. It does not matter how many ectopics, and it does not matter how strong those ectopics are, they just bounce off. It's not going to affect the heart itself. Basically, what we're looking at is, remember, depolarization. Sodium's on the inside now, potassium's on the outside. Now, as they get closer back to about this point right here in the repolarization, that's from the top of the T wave down into there. If we get an ectopic, an extra beat that gets generated, because remember, it regenerates, and particularly that it's going to be coming from the ventricles, so it regenerates going back up this way. So we've got that whole process that's in flux going back up here. If we get an early beat that gets hit on this part of the T wave, and it is strong enough, we can have a condition that's called R on T phenomenon. Your patient immediately goes into ventricular fibrillation where the heart just begins to quiver, okay? And the patient is in cardiac arrest instantly. The good news about that, it's easy to treat if we have a defibrillator there. Questions? Yes? We call that the ST segment. Now, I'm not worried about you knowing about the ST segment because that's what we're going to be using to identify if a patient is having a heart attack. We'll talk a little bit about the importance of that probably in the last 2 or 3 weeks of the semester. Saw a hand over here. Okay, anybody else? All right, so guys, when you come back on Wednesday, remember what I told you, and then your reading for next week will be there as well. I will record a video so we don't get behind, and I'll have it posted up by Monday at the earliest for what normally would have been class, okay? If you need anything, I'll be here for a few minutes. Go get you some lunch.